Okay, Assalamualaikum and good morning, everyone. Thank you for joining today's webinar. My name is Nurul. I'm your moderator for today's session, which is the last session for this year, for the weekend with IAPMD. And it's a great pleasure for me to introduce our speaker today, who is going to present on ocular pathology. She has an eye-catching title, which is Bird's Eye View, in which I really look forward to listening to her talk today. So a little bit about our speaker, Dr. Wan Azura Wan Yaakob. She graduated from University of Malaya in 1990 and obtained her master in pathology from the same university in 1999. She subsequently went for her subspecialty training in ocular pathology at Manchester Infirmary Hospital in UK in 2010 under Dr. Lucien. So with 24 years of experience as a pathologist and being the only ocular pathologist, she has been receiving many referral cases from all over Malaysia. So besides her diagnostic work, she previously served as the head of unit in Hospital Seremban, Hospital Selayang, as well as head of pathology department Hospital Serdang. And currently, Dr. Wan Azura is a senior consultant in Hospital Serdang until her official retirement soon, which is on 16th of April. So we are very, very honored to have her here today to share her knowledge and vast experience on the topic of ocular pathology. So without further ado, please join me in welcoming Dr. Wan Azura. Dr. Wan, the floor is yours.
Thank you, Dr. Nurul Akmal. Okay, first of all, I like to say that sorry that I may seem to be looking up because my son, I'm using my son's computer, Haris Ibrahim. So I hope you just bear with me. Boleh dengar ya?
Boleh.
Okay. Thank you, Dr. Nurul Akmal. Assalamualaikum and good morning to everyone. Thank you for the very complimentary introduction. Yes, the one that I need to correct is the final one that I'm waiting for retirement. I'm on leave now until 16 April. My retirement officially is 16 April. So I'm on leave now. Currently a housewife lah. At the moment, tak ada kerja lagi ya. Okay, today's I'd like to thank the organizers as well for inviting me, and glad to know that it's the last because I made it to the last. I'm sorry for the postponement earlier on. Actually, I was ready in February, but because I was going for a holiday, I was too excited. I didn't want to present. So I told Dr. Zahra I can present in March, and fortunately, it's the last day I made it. Thank you very much to the organizers for inviting me. All right. Anything else that I want to share? Okay, I think that's all the general things that I want to say. Okay, now I will, without further delay, I think I will start off with the presentation. Okay. Just to tell you a little bit that I'm not really a subspecialty, of course, a very short course in ocular pathology in Manchester and a little bit in Liverpool, some time ago lah, in 2010. All right. Actually the topic of my presentation is bird's eye view. Tapi actually the meaning of bird's eye view is a very general view, but actually I will focus on things that people refer to me, things that commonly occur in our practice in Serdang, and also some experience when I was in Selayang as well. Yeah. So I will share some cases. I will share important things only. Although the topic is bird's eye view, it won't be too general. Yeah, I will focus on what is important and what you all should be able to report lah at your level. I mean, as very senior or junior specialists. And also, I think you don't need to refer at the moment, because you can't also, because Dr. Amizato is still in training in Liverpool. Yeah, when she comes back in August, you you can refer to her lah. Okay, so just to share with you the contents of my presentation is a quick anatomical revision. So because I know when you get an eye lesion, you cepat-cepat buka buku anatomy. Where is this? Where is that? You know, because it's not every day that you get a specimen from the eye, right? I'm sure. Four big spectrums lah, common and commonly rare. They can be rare, but sometimes it's common. Encountered ocular diseases in daily practice. Case presentation with emphasis on interesting and important issues, the ones that you all refer to me, the ones that I see in my daily practice, yeah, and new but not so new emerging diseases and take-home messages. So just a quick revision that things that might be helpful in terms of anatomy, because as I said just now, you all cepat-cepat buka buku. Ni kat mana? Ni kat mana? You know, all those sort of things. Okay. Firstly is the eyelids lah. Eyelids, please don't exclude them, because these are the common things that you receive. Common lesions are from the eyelid. The canthi, which is singular, is a canthus lah. Corners of the eye, the canthus. Caruncle is located near the medial canthus and contains sebaceous glands. These are very important anatomical sites. Tarsal plates are made of connective tissue and strengthened eyelid. They contain meibomian or tarsal glands, which secretely pit to create airtight seal when closed, and also prevent eyelids from sticking together. So these are the few things that you just be aware of lah, yeah? Some of the cross-section of the anatomy and all that. So if you get a specimen of the eye, you cepat-cepat lah have a glance at all these anatomical sites. These are the muscles, also important. This is the normal anatomy when we were undergrads, right? So it just have a quick review of some things that you might want to see. Anterior chamber, posterior chamber, where are the sclera, where are the retina, yeah, optic nerve and all that lah. Okay, next one. Okay, as for the cornea, we know that okay, I think it's quite commonly encountered in your daily practice, because the most general of ophthalmologists would biopsy all these lesions. Yeah, epithelium, we have the Baumer layer, you have the stroma, Decimedes membrane, endothelium. Just be familiar. And parts of the conjunctiva as well. Non-keratinized parts of the fornix, basically non-keratinized squamous goblet cells, and then the tarsal layers are keratinized squamous. Yeah. So sometimes they might say they take it from the fornix, sometimes they might say tarsal, but you see different things, you know. So you just have a suspicion there lah, from the origin, the site of origin. So conjunctiva is quite commonly seen, like non-keratinized squamous with goblet cells at the fornix. Yeah? Goblet cells, sometimes you will see these goblet cells, adenoid layer, fibrous layer, which we call substantia propria. Yeah? And then helpful surgical terms. Helpful surgical terms will help us in our daily practice as well. We were not taught of all this, but the surgeon will give you all this PK. Sometimes they just use short form, right? What is the PK? Penetrative keratoplasty. Okay, full thickness transplant cornea, the full thickness until the decimates lah, endothelium as well. Lamella, LKP. They just give you LKP, PK, that's it, and you figure out for yourself. Removal of the diseased cornea, decimate, endothelium are left behind. So these are left behind tissue lah, LKP, lamella. Enucleation, I think you're quite familiar with this. Removal of eyeball with preservation of all other periorbital and orbital structures. And exenteration, everything is removed with eyelids, soft tissue, etc. Yeah, I think you are quite familiar with this. When they use all the abbreviations that we have problems with. Yeah? So we go to the pathology. So can you see the top, the A? No? I also can't see. Okay. So A is I've divided into 5 large areas: tumors and pre-malignant, inflammatory, dystrophies, and four, congenital. Congenital pun all the simple ones that you get every day. Don't worry, not the rare ones. I won't touch on the rare ones. Okay, for the tumors and premalignant lesions, okay. Commonly sent to me or regularly sent to me is the OSSN, ocular surface squamous neoplasias. And also the second part is a primary acquired melanosis, the melanotic lesions. Yeah? So these are the two common ones. I'm sure you agree with me. Those who have sent a referral to me, these are the common two. Actually, number one is the one that you always commonly send. Yeah. All right. So definition of ocular surface squamous neoplasia. Squamous cell neoplasia may occur as a localized lesion confined to the surface epithelium of the conjunctiva, which is similar to our CIN of the cervix. As a more invasive squamous cell carcinoma that has broken through the basement membrane and invaded the underlying stroma. So the pre-malignant condition is the CIN. Sometimes we still use the CIN here. And then currently the accepted term for the localized variety is conjunctiva intraepithelial neoplasia and still CIN. Yeah? So it's sometimes it may be confusing with our CIN of the cervix. All right. However, other authors prefer the terms dysplasia, mild, moderate, severe, and carcinoma in situ when the whole thickness is involved, yeah? Where there are no longer normal surface cells and process midterm carcinoma in situ. Those cases where cornea is invaded by the are usually called conjunctival cornea, intraepithelial neoplasia if it involves the cornea as well. And squamous neoplasia constitute the most frequent primary malignant of the ocular surface. Yeah? And sometimes similar to CIN of the cervix, HPV remains some suspicion, but it's still unclear, right? And also there is a same like 16, HPV 16, 18, and uterine cervical carcinoma. However, multiple studies worldwide have failed to document an unequivocal association, yeah? All right, so it's not really proven to be associated with HPV. Okay, I just share you a case. Elderly Malay gentleman presented with growth on conjunctiva increasing in size. Okay, the lesion usually the OSSNE they always present, commonly present, not always, as papillomatous. Okay, papillomatous lesion at low power with the fibrovascular core and also the surrounding dysplasia. It can be very subtle. The dysplasia can be very subtle and very mild. Yeah? You see, you can see that there is already some arrangement or haphazard arrangement of the cells. Some are larger, some are the nucleus, some are larger, some are small. You know, haphazard arrangement and dyspolarity. So some of the red marker there can see that there is already some invasion into the stroma. Small tongues, larger ones, and dysplastic ones. This is a higher view, small irregular tongues invading into the stroma. Very subtle, right? Okay, very subtle. This one looks more dysplastic, right? I'm sure you all agree with me. More dysplastic from top to bottom. And when I look closely, there is early invasive SCC. Okay, this is one of the referral cases, if I'm not mistaken, sent to me. So sometimes you are unclear. Well, I try to help you all by looking at it more clearly, more specifically. All right. So we move on to PAM. Okay, this one previously the terms precancerous melanosis, benign acquired melanosis, banyaklah dia punya terms and all that have been used for PAM. However, WHO has proposed a primary acquired melanosis as a neutral, non-judgmental term instead of precancerous or benign acquired melanosis. Yeah. Acquired. So it's something primary. The term primary was introduced to separate this condition from conjunctival pigmentation secondary to other things, like secondary to local disease, post-inflammatory, skin color. If you look at the textbook, there is also called complexion-associated pigmentation, and systemic diseases, Addison's disease, neurofibromatosis, and others, right? And the term acquired was retained from Zimmerman's classification to emphasize the differences between this condition and the blue episcleral and scleral pigmentation of congenital melanosis oculi. Okay, this is one of the lesions of PEM. You can see that there's some dysplastic changes, very mild. Okay, very mild. Here they put without atypia, but the pigmentation is very, the basal layer is very abnormal. It looks, the cells look larger with more pigmentation, right? Okay, with some atypia where there is this polarity increasing, then pigmentation extends upwards into the superficial layer of the superficial layer. Okay, so it's more dysplastic or atypical at this point. Okay, I give you a case. 60 years old Chinese man, painless lesion, progressive increase in size for 6 months, lesion whole of inferior conjunctiva with a few satellite lesions. Okay, this is the clinical picture. There is a blackish pigmentation in the conjunctiva. You can see. I thought the patient looked a bit jaundiced, but they say it's the lighting. Yeah, the sclera is not yellow, but there is a pigmentation, a pigmented lesion that we can see. However, in low power, you can see there's a lot of pigmentation going on. The epithelium still is intact, but there is a lot of pigmentation within the stroma, yeah, or substantia propria. We call it in conjunctiva, yeah. Okay, closer view. You can see the epithelial cells appear dysplastic, pigmented. Basement membrane appears intact, but spillage of cells are seen into the substantia propria. Okay, the pigmented cells appear dysplastic, enlarged nuclei, prominent nucleoli. Yeah? Lesion B45, stroma, positive basal stroma cells. So with this, the lesion is actually has a pre-existing PEM and has invaded into the stroma, becoming a malignant melanoma. Okay, so these are the pre-malignant conditions. In malignant tumors, of course, the most famous one is our melanoma. Yeah, ocular melanoma, most common primary eye tumor, adult, second most common melanoma of the skin. Uveal melanoma is common, choroid, eyes, iris, and ciliary body, yeah, in any of 3 layers. So uvea, okay. You also be familiar with all the parts in the uvea. There are 3 areas: iris, ciliary body, choroid, and the most common is the choroid. Choroid is the most common area whereby melanoma can exist, yeah. And then they can extend to the optic nerve because it's posterior, and it's a common site. Huh? So for anatomy, just to refresh you all with the anatomy, you can look it up in the book. Yeah. Okay, this is a very specific view of the 3 layers: sclera, choroid, and retina. Yeah? Retina, there's not much of tumor going on. Very rare, unlikely to be biopsy. I don't know. I've never seen other than for kids, but not for adults. So the choroid, you can see that it's very pigmented, very vascular. Yeah? Okay, the choroid layers has got all these layers, vascularity, and it has the retinal pigment epithelium above, yeah, the Brooks membrane, and the sclera below. Yeah? And optic nerve is very nearby. So for malignant melanoma, we use the calendar classification. As you all know, there's spindle cells, type A, type B, spindle B, and epithelioid cells. But usually there is combination of epithelioid cells or spindle or A or B. Yeah? There are combinations. Usually they are not really, original epithelioid or spindle. This is the histological picture. You can look it up in the ophthalmology book. Yeah, I took it from there. And these are the staging that we use. Okay, largest basal diameter. Okay, you can look this up as well according to your tumor. So just to highlight one case, a 55 years old lady, left eye, large choroidal tumor, MRI, no extrascleral extension, post left eye enucleation. Specimen cut section shows a blackish tumor arising from the choroidal layer, 10 times 10 times 7 mm. Medial to the optic nerve, no extension into the scleral surface. Yeah. So this is a very just adjacent to the lesion. You can see that the retina is always lifted up somehow or other, maybe some edema within the space. The choroid can be seen, which is vascular, and sclera adjacent to it. Yeah? And then as we go progress ahead, we can see that there is expansion of the choroidal area with this lesion, pigmented blackish lesion, and a more higher view. Yeah? Pigmented tumor cells, aggressive tumor. All right, you can see prominent enlarged nuclei, prominent nucleoli, and pigmented blackish pigments in the cytoplasm and mitosis. Sometimes I notice that difficult to see mitosis, difficult to see, but the cells are already very dysplastic. But mitosis is very difficult. Prominent nuclei, yes, easily to see, enlarged nuclei, easy to see. Mitosis is quite difficult. Maybe sometimes the pigment obscure it. Huh? So case one is choroidal melanoma, quite obvious. Another case, 69 years old man, a hyperpigmented conjunctival lesion. Specimen received tissue without irregular lesion, 10 times 8 times 8. Margins were tagged. So this is another case of a conjunctival melanoma, yeah, full thickness invasive tumor. But maybe it doesn't have a PAM as a pre-malignant condition because it's very exuberant already from the start. I don't see any PAM. So again, the same issue. So this is conjunctival melanoma. So the two areas which are very commonly seen for melanoma is our conjunctiva and our just now is choroid, the choroid. Another lesion that is important here, lymphomas. Lymphomas is quite common. In Sedang, almost every other case is a lymphoma. Usually non-Hodgkin's type, can involve intraocular, orbital, and nasal. Orbital, very rare. Difficult to see, but intraocular is commonly presented. Decreased vision with uveitis is usually the orbital one. For biopsy, of the conjunctival, for the fluid, we see it in the fluid. Symptoms of gradual income mass effect, proptosis, and conjunctival mass are common presentation, and 30-35 are associated with systemic lymphoma. So follow the WHO classification. So basically, this is lymphoma, mostly of the this one is it. Intraocular, orbital, the aqueous fluid and all that is mostly other types of lymphoma, but these are the common lymphomas, and mostly they are low-grade lymphomas. Okay, this is non-Hodgkin lymphoma. Okay, nodular infiltrate of orbital tissue, increased magnification, monotonal cells like we see in our normal lymphomas, but they are usually low grade, non-Hodgkin's type. This is a Burkitt's lymphoma in a child. This is from our ophthalmology book. So there is another as intraocular lymphoma. A look at distinct clinical features that can establish diagnosis and guide to treatment. This is by Prof. Sarah Coupland, ocular pathologist, University of Liverpool. I had a opportunity with her for a very short time, but Dr. Amizato now is with her. So I think when Dr. Ami comes back, I'm sure she will privilege you with all these lymphomas, because Prof. Sarah is Dr. Amy's supervisor. So intraocular lymphomas are rare malignancies that display a wide array of clinical manifestation. All are non-Hodgkin's type. Vast majority are B cells, right? Most experts now group these entities based on site of ocular involvement and whether the disease is primary or secondary. Using this scheme, the intraocular lymphomas can be subdivided into primary, vitreoretinal, or primary uveal lymphoma, and secondary, which is quite rare, yeah. So this is the intraocular lymphomas, primary, vitreoretinal, primary uveal, and secondaries, yeah. Okay, you can see here there are also the diffuse large B cell type. Okay, we rarely diagnose this because we do not have enough specimen in the vitreous fluid. Okay, so vitreous biopsy is not diagnostic in all cases. Supplemental techniques can be helpful in confirming our normal immunohistochemistry. Yeah? But I think now we have to use PCR. When I was in Selayang, I used to get a lot of this type of fluid. Yeah, but we cannot really confirm the diagnosis. It's up to the clinician where they can send to confirm the diagnosis, and also a high index of suspicion for them, yeah. So okay, as I said, in Selayang, I saw a few cases. So this is one case of it. 76 years old Chinese lady referred from Hospital Melaka, progressive blurring of vision. 6 months, she feels that there are floaters in her eyes, treated as left posterior uveitis. Vitreous tab shows CNS no growth. Diagnosis to rule out primary vitreoretinal lymphoma. So for the fluid, these are the cells seen. I think you can appreciate the normal lymphocytes, the smaller ones, versus the larger ones, which have enlarged nuclei, high NC ratio. Yeah. So usually I ask for one PEP and one cell block, not to waste the cells. Yeah. And confirmation, I think the clinician should send for PCR. Okay, for secondary tumors, don't forget there are also direct extension or metastatic. Yeah, these are some of the cases of secondary tumors, acute leukemia, and some tumors. Yeah, we won't go there. Metastatic tumors, you can figure it out. If there is not all are melanomas. Yeah, please exclude secondaries too. If there is a history of a primary somewhere else. Okay, just we go to inflammatory and autoimmune. Okay, this is under the category for us as new emergence in the eye lah, but it's actually basically seen elsewhere in the pancreas, in the liver. Yeah, I'm sure you all have seen IgG4 related disease of the ROD. Yeah, right. Okay, so IgG4 is a systemic condition in which in fibro-inflammatory lesions rich in IgG4 plasma cells can be present in single or multiple organs of the body. When the disease manifests in the eye or orbit, is referred to as IgG4 related ophthalmic disease. Yeah, and commonly seen as painless valley on the lacrimal glands. This one we get quite a lot in Sedang. Every other case will come as to rule out IgG4. Yeah? Other commonly affected parts of the eye and orbit, extraocular muscle, orbital fat, intraorbital nerve, etc. But the most common is the lacrimal gland. Diagnostic criteria combine physical examination, imaging, histologic findings, detailing the number of G4 plus cells in a high power view and the ratio. Yeah, so it's quite a tedious work for us. Okay, imaging can aid in the diagnosis, medical treatment with corticosteroid or immunosuppressants. That's why they want to see, want to confirm the disease. Yeah. So the differential is always either IgG4 or lymphoma lah, the differential diagnosis. So frequency of IgG4 ROD related disease, location as I said commonly is lacrimal gland and others lah. IgG4 disease tends to occur in a younger group of patients, 55, considered young. Okay lah. Okay, a fat man and woman more equally, and IgG4 ROD may have an increased risk of non-Hodgkin. I think the ultimate disease would be non-Hodgkin, right? Compared to patient with pancreatic form. Three major criteria that we need to look for is dense lymphoplasmacytic infiltrate, focally storiform fibrosis, and sometimes plus minus lah, this one, obliterative phlebitis. And the diagnosis of IgG4 related disease can usually be in two of the three major criteria, most commonly in combination. Commonly the combination of dense lymphoplasmacytic infiltrate and storiform, number 1 and number 2, right? And minor is the others, non-obliterative phlebitis and eosinophilia. Okay, usually there are T lymphocytes. Okay, this one in one case, increased lymphoplasmacytic cells. You can see, and I think at this power also you can see a lot of eosinophils. This is a case from Serdang. We saw this storiform fibrosis. So kalau diffuse fibrosis, patchy, I think it's not so accurate lah. But if it's a storiform pattern that we see in our leiomyoma, fibrous sarcoma and all that, okay, we quite take it seriously. All right. So these are the same lah. Okay. And just to say that other potential findings include germinal centers, obliterative arthritis, more common in the lung. Okay, the presence of histiocyte granulomas, giant cells, necrobiosis is unusual and suggests alternate diagnosis. So it's not really IgG4. If we find giant cells, necrosis and all that. And on immunohistochemistry, there should be more than 10 IgG4 positive plasma cells for high power view and a ratio of more than 40%, IgG4 over IgG. In lacrimal gland, we need about more than 100 IgG4 cells per high power feed, right? Yeah, okay, this is just an example of increased IgG4. So sometimes we need the serum IgG4 to really confirm, although it's not necessary, although elevated IgG4 level are neither necessary nor sufficient. 40% with biopsy proven will have a normal IgG4. Because actually the clinician in Serdang also do not send already IgG4. They say if you say it's so, they believe us. If you say not, they also believe us. Okay. With our criteria, all right? So this was taken for iWiki. All right, this is we move on to the next one, dystrophies. I hope I'm not, okay, I'm still on time. Dystrophies, they are genetic, rare, often progressive eye disorders in which abnormal material accumulate in the cornea. They may be asymptomatic or cause visual impairment. This one, I just want to tell you all because I've seen it in Selayang. Selayang gets a lot of tissue from Hospital Sungai Buloh, because they are the center for cornea, Okay, these are a long list of dystrophies, but the common ones I will highlight to you that we have seen because we have a multiracial community, so we can see all this because sometimes they are very rare, but we have a lot of race in our country, so we need to be aware. Sometimes mixed marriage and all that. Okay, case 4 from Sungai Buloh. If the cases don't tally, just excuse me lah. Sometimes I tend to jumble up. From Sungai Buloh Hospital, 46 years old Iban man from Sarawak, complaint of blurring of vision, photophobia, and foreign body sensation in the eye. Okay, this is the H&E of the cornea. Sorry, the picture is a bit dirty. The slide was not cleaned properly by me. My mistake. And we can see that the cornea is abnormal lah. There's some thickening in the center area, right? So you can appreciate there's some thickening there. Past here, Congo red. Yeah, past here to me it doesn't really pick up lah. Yeah, Congo red is more prominent. Okay, for this case I didn't have the fluorescence. I didn't get the picture, but it was lah. This we call subepithelial because it's mostly in the subepithelial area. Okay, there's some accumulation there. Is the gelatinous drop, subepithelial amyloid deposits, Congo red positive. All right, and disease onset of first or second decade. But this patient seems to be older, I think. Yeah, 46 years old, but the age doesn't really matter. And the marked visual impairment, but the diagnosis was made for him. Okay, this is called Mulberry cornea. Okay, this is another case, Hospital Sungai Buloh as well. 68 years old Chinese man, decreased vision, cloudy cornea on examination. Okay, this is a H&E. You can see that the cornea is not normal. There are some deposits within the stroma. Okay, this is Congo red. You can see it below the epithelium and also in the stroma. And this is the polarizing green bifurcations. This one I managed to get. This is a case of ours in Selayang from Sungai Buloh. All right. So stroma corneal dystrophy, rare but not really seen lah. It's very rare. Lattice, this one we call lattice corneal dystrophy, where the first type 1, first decade, type 2, third, and older patients. And then we have Fuchs. Fuchs corneal dystrophy is one of the posterior dystrophies characterized by abnormality of corneal endothelium and decimate membrane. So I'm progressing from subepithelial, stroma to posterior. Okay, this is Fuchs dystrophy. You can see the cornea is not normal. Vesicles in the epithelium, edema of the stroma, and gutted. We can see gutted. I hope you can't hear the rain because it's raining here. Sorry if there is a bit noisy. So by definition, corneal guttata are droplet-like accumulation. Maybe you might come across the word guttata, which is a funny word. It's a droplet-like accumulation of non-banded collagen on the posterior surface of the decimate membrane. And the presence of focal thickening of decimate membrane is histology butane. And then we get bullous keratopathy. I think this one commonly sent to you all. Okay, bullous keratopathy is actually edema of the cornea resulting from failure of the corneal endothelium to maintain the normal transparent dehydrated state of the cornea. Most probably it comes from complication of Fuchs. The rest occur during surgery, cataract removal. Okay, so don't be surprised if you get this diagnosis, bullous keratopathy. What is this? Okay, so from a surgery, cataract removal is an outcome. It's an outcome. It's just you just describe it and what you see. All right. So after cataract is called pseudophakic if an intraocular lens implant is present, and aphakic if no intraocular lens implant is present. Okay, so don't be surprised if you have this. So just to show you a case of bullous keratopathy, left eye pseudophakic bullous keratopathy, underwent left eye penetrating keratoplasty, especially its recipient cornea. Okay, so we can see all the features that I have told you. There is an outcome. Vesicles, bullae, increased corneal thickness, fewer endothelial cells, right? And lastly, I think this is the last, congenital. There are not many congenital specimens sent to us, I'm sure, but these are one of the common ones. 17 years old girl from Sarawak, corneal lesion since young. On examination, limbal lesion. So limbus, where is it? It is between the cornea and the sclera, the junction there. So here we can see like a dermoid pattern where there are fat cells, there are muscle, there are glands, right? So it's a dermoid cyst. So it's at the limbal. So it's called a limbal dermoid. That's all. Occur in the temporal or superior temporal limbal area, but may involve entire cornea, choriostomas, congenital rest of benign tissue elements in abnormal location. Contain epidermal appendages, fat, smooth and striated muscle, and cartilage. You can wherever we get in a dermoid, yeah, are covered by cornea or conjunctival epithelium. Can be part of a golden hair syndrome, yeah, where triad of dermoids, accessory or auricular appendages, yeah, like this in this picture. This is a golden hair syndrome. Okay, just to touch on one lesion that is also commonly sent to me as a referral, melanocytic lesions in children. We are alarmed by this, yeah, because we are afraid that these kids all have malignant tumors. Conjunctival melanoma, yeah, I can't see. Okay, usually malignant ones are affect middle-aged and elderly, and commonly seen in the Caucasian. Children are rarely affected, yeah. Children are rarely affected by the disease, and very few reports in the literature. Don't be alarmed. Conjunctival nevi are common in children, but malignant transformation is rare. Nevertheless, please suggest a long-term follow-up if you feel that there is some suspicion. They might be atypical. So just suggest a follow-up, but don't diagnose malignant straightforward, yeah? Outright. So this is conjunctival melanoma in a child clinical report by Saudi Journal of Ophthalmology 2018, yeah? So Indian boy, a large lesion, anterior segment of optical coherence, topography, revealed cystic spaces, underwent conjunctival excision biopsy, no touch technique, window, okay, all this thing lah. So actually, it is not tumor, very rare. This case, sorry, I didn't finish this case. It's not tumor also, yeah. But I would like to highlight this lah, conjunctival nevi in children are relatively common, indicating the vast majority do not progress to melanoma. I like to emphasize that. But the common lesion that we see is inflamed juvenile conjunctival nevi, IJCN. Okay, whenever you all send to me, I always put this diagnosis. After I consult with Dr. Amizato, we feel that it's still IJCN. All right. Okay. In their study, 48% of compound nevus constituted of IJCN. Yeah? Common lesion being the bulbar. Authors concluded that some are excised because of suspicious of malignancy. Okay, we feel afraid of this. Okay. And also, ophthalmologists should be aware of the entity, right, to avoid misinterpretation. So this is a case, 12-year-old Malay boy, left eye conjunctival swelling since he was a newborn. Swelling increased in size. Okay, can see it's very busy, very thickened, vascular, pigmented, yeah, S100 positive. So this is the inflamed juvenile conjunctival nevus in young patients, yeah. And they have found out that 25 have simple compound nevi, 75 have simple compound conjunctival nevi, and 75 compound nevi. Yeah, and some inflammatory like cells like lymphocyte, plasma cell, eosinophil. So do not be alarmed. Yeah. Okay, I think I will go here. All right, this is my last slide actually. Sorry to take up a bit of your time. This is an eagle. So I think from the small bird that was around looking, and I think if you have, you can take a little bit of this lecture, you have landed as an eagle. All right, in the ophthalmology, pathology. All right. Okay, some take-home messages. The eye is a small organ but has many wide variety, many more than what I have mentioned. Can be anything, different type of tissue in the orbit, and it has specific, unique, and specialized anatomical part of its own. I hope that more pathologists will be interested in this subspecialty, and I hope more time is given to pursue this subspecialty. And as I said, Dr. Amizato is there now with Prof. Sarah Coupland. Prof. Sarah also knows about our Malaysian cases because she has been here. Dr. Lucienne and Dr. Richard Bonchet. I don't know whether he's still around, but the two ladies are still around. Okay, I think that's all for me. Thank you very much.
Okay, thank you, Dr. Wan, for a very interesting presentation. So many interesting cases that you shared just now. I think I did refer one case for IgG4 related disease to you. So we have quite some time to for question and answer session. So we have one question from the meeting chat from Dr. Mazita. Her question is there any special specimen container with additive for the vitreous fluid collection from patient? Clinician wants to rule out lymphoma.
Okay, you can hear me. Actually, it's just the normal specimen that we use for our what do we use for any specimen. It's a simple common specimen that in Selayang I was quite some time ago, but it's the normal specimen that you collect for any specimen in the tube. Yeah, and there's no specific specimen bottle. Okay.
Okay, there's another question from Dr. Noraini. Is there, she said, thank you for the generous and interesting cases you shared. Just to ask, in cases of IJCN, will sock stand helpful to differentiate with melanoma?
Will apa dia? Sock stand?
Will sock stand helpful to differentiate with melanoma for cases of inflammatory juvenile conjunctival nevus?
I don't. Most of the time they use HMB45. Because HMB45 is quite specific lah. And then it only sometimes very patchy. If it's more diffuse, it extends into the stroma. More intense, it may be just suspicious. But I think the most we write in the journal that the most that they will put is atypical melanoma and not outright, not outright melanoma in a child. Please don't put that because it will quite traumatize the child. At least have a close follow-up. Okay, the most you can put is atypical, but don't put outright melanoma. Okay, but I think the as most HMB45 also can help. Maybe Soxan, if some people do not have that, but if you have, okay, why not have a go?
So I guess this kind of cases yang akan jadi referral cases kan, Dr. Wan?
Apa dia?
Kes macam ni akan jadi referral cases selalunya kan?
Yeah, that's right, definitely. The IJCN is from dulu lagi, from 10 years ago. Every year I get two or three. Every time I do, I give a little bit of note lah to the pathologist. So I hope that these people, you all can learn from that lah. But from this talk also, I'm giving you some caution lah. Do not diagnose malignant outright in a child. Okay.
Okay, there's no more question dekat meeting chat ni. Tapi for example, I have one question regarding the first case like CIN. Is there any your approach to CIN? You do more levels or do you do stains? Any special IC like KC7 or more of how do you approach cases like how to differentiate with reactive? Do you have to do levels to see more and more macam dysplastic changes ke macam mana?
Of course. We approach it as normal SCC or CIN of the cervix. We do levels. We do stains if necessary. If you are still not very confident, levels show around. You just do what you can lah. I mean, as for cervix also we do show around, right? And we and also clinical suspicion. Clinical suspicion also important. Sometimes the lesion is seen already. There's a large lesion there. I mean, I can't expect. I mean, with all the clinical plus the features that we see in histologically, I think we can confidently say that you can say early SCC, if you're not confident with the outright SCC, because there is a breach of the basement membrane. Once there's breach, and then you do levels and all that, you can see more spreading. I think it's quite confidently, you can confidently say, yeah.
Another thing, conjunctival grossing. Sometimes we receive conjunctival specimen, which is very small, but they tag in one, the specimen they tag. Do you, can we sacrifice one of the margins, or how do you gross conjunctival specimen? Because sometimes it's very small, one of the margins that susah nak dapat ke, you really have, you must submit all the margins to see the margin, because it's very small. Sometimes one of the margin is sacrificed. Especially
I think our practice is we paint first, whatever it is. Whatever the tag we paint, and then whatever we can see, the color is muncul dalam slide tu. I think we can say that we have but we have to paint whatever is tagged, and we cannot sacrifice any margin because they want to know. And if they don't get it, I think they will blame us lah. So whatever it is, we try our best. Paint first before you cut. Paint first before you cut. Identify all the margin. Sometimes you are lucky that they tag. If they don't tag, it's worse. But it's not our fault lah then. But if they tag, they make the effort to tag. Please paint before you cut it, so that you will get anything that you can see on the slide is helpful. Okay, don't exclude any margin. Okay.
Okay, thank you so much, Dr. Wan. So there's no more questions. Sorry.
I have a question. Dr. Sugunaya, we frequently receive a corneal button for keratoplasty, and they did a corneal transplant. Usually they will just submit the button just like that, or do we need to serially slice it like a cyst and submit it in cyst wall? And then what are the special stain that is compulsory to be performed with this corneal button?
Actually, for transplant corneal button too, I don't know what they want to see. Usually the transplant cornea is just, firstly is the sectioning. I think you just take one slice, submit both, come back, it's very small, right? Or you can slice it up as long as you can see the layers. I'm sure you divide into 4 or 2 is enough. And then at the end of it, as I said, actually the outcome is a bullous type of presentation. It can be a bullous type of presentation. It can be not hasn't reached the bullous complication. Maybe a rejection type. Sometimes the rejection is mostly same as any rejection. Mostly lymphocytes. Lymphocytes with increased vascularity. If you read the books, there are some features, but I don't know whether they really want to see the rejection part. Usually they want to just remove it and put another one in. That's what I'm trying to say. Sometimes you just want to remove the rejected part and put in another new one. That is their aim lah, the ophthalmologist's aim, to get another cornea button in. But whatever we receive, we report. We report as we see. Okay, either it can be a rejection picture, or it can be a outcome of bullous. The final outcome will be a bullous-like lesion.
Thank you.
Okay.
Is there any question from the floor? You can unmute yourself. Okay, if no question. So before we end the session, again, I would like to thank Dr. Wan. We are very grateful for the time and effort that you took to present this and to share the knowledge with us lah. So since you are retiring and now on leave, we wish you all the best in the exciting
new phase
of your life. Yeah. Okay. Yes. And now we are waiting for Dr. Amizato to receive all the. We will send her many cases.
She was supposed to join, but then she said, "Doktor, pukul 3 pagi kat sana, saya tidur."
Yeah, she's having a course there.
Yeah, and then she's in a congress somewhere in Wales. So saya kata tak apa, when you come back, you take over. So
Okay.
I wish her all the best, and also I like to thank the committee for inviting me. Also like to wish all my juniors a good future ahead. I mean, learn as much as you can, and provide a good service to every all the clinicians and everyone lah that require our service. Yeah. Also, I would like to wish selamat berpuasa lah to my Muslim friends, and eventually also selamat hari raya lah, which is longer way to come. Okay, lambat lagi.
Okay,
So sekarang selamat puasa dulu lah. Ya.
Okay.
Terima kasih banyak-banyak.
Okay, thank you everyone for attending today's webinar.
Okay, thank you, Dr. Nurul Akmal, as a moderator for today. And on behalf of IAPMD committee, with IAPMD Live, I would like to, we are so humbled and grateful to have Dr. Wan as our final speaker for this season, second
Closing
season.
ceremony,
Yeah, closing
Closing
ceremony.